change in the countries. The other thing is simulators. I know I've asked about this Mikoto. It's quite expensive, and I'm quite fascinated with how it can help in training. So if it can be made available, not really like permanently, but maybe we can assist when you have local trainings. Maybe it can be brought so that we can help young gastroenterologists. And to finish is, of course, mentorship programs and follow-up of these courses. Once we are trained here, if we can get follow-ups and attached to a mentor, it can really help. And of course, a big dream is to get maybe centers of excellence in different fields of gastroenterology. Maybe in Africa, we divide in several countries. One country can specialize in more of ESD and third space. Another country, mostly in the US. Then at least we have several centers of excellence where different trainees from different parts of Africa can go and train. Thank you.
Bonjour tout le monde, je suis Jean-Jacques Matimbo Koyondele, je suis hépatogastro-entérologue de la République démocratique du Congo. Alors, prime abord, j'ai remercié le membre d'organisation de cette conférence et des grands congrès que je passais, c'est pour la première fois de passer ici en Égypte. Je félicite le professeur Mustapha pour cette belle organisation. Et son équipe, Ahmed, il ne faut pas l'oublier, puisqu'elle était tout le temps avec nous. L'équipe de Fujifilm. Et en particulier, je remercie ma professeure qui est là présente, Wafa. Alors, je peux être droit au but.
Jean-Jacques, laisse-moi juste une minute. So Jean-Jacques is from Democratic Republic of Congo, and he's very grateful for the opportunity to be here today and thankful for the organization of the Congress because it's his first time here in Egypt. And he's thankful for the Fujifilm and Roya teams.
Signalons que la République démocratique du Congo contient plus de 100 millions d'habitants. Dans la capitale, nous sommes à 12 millions, plus de 12 millions. Et nous regorgeons essentiellement autour de 20-21 en gastro-entérologues. Et ceux qui font les endoscopies, ils sont moins de 10.
So just to sum it up, 100 million population, 12 million in the capital, for only 12 gastroenterologists?
Yeah.
12 gastroenterologists.
Alors, je suis aux cliniques universitaires de Kinshasa. C'est là où on forme des gastro-entérologues. Nous passons des stages de 2 ans pendant les cursus en France. Je suis parmi des gens qui ont bénéficié de ça, pour apprendre l'endoscopie diagnostique ainsi que interventionnelle.
So your training center is the unique training center in Kinshasa, and you send all your fellows to France for 2 years to train for basic endoscopy, and you were one of the trainees. Okay.
Alors, le problème, quand vous retournez au pays, vous avez le sérieux problème, c'est que vous n'avez pas de matériel nécessaire, pas de fournisseurs.
The problem is when you come back, you are fully trained, but still you don't have the equipment necessary to practice your...
Pas de fournisseurs de matériel, et puisqu'il n'y a pas de point focal. Peut-être pour Fuji, c'est une occasion d'intervenir pour venir au Congo et précisément aussi à Kinshasa pour la formation. Fujifilm, c'est important de voir ces chantiers.
So as I understood, Fujifilm is not represented officially in RDC, and you are asking them actually to have a permanent representation in order to improve the equipment, but also education and training.
Pour former les étudiants en endoscopie, nous avons besoin des stimulateurs que nous n'avons pas, puisqu'on sera obligé d'aller sur le patient avec des risques de complications. Ça pose problème. Il faut que ces gens puissent apprendre par rapport aux stimulateurs qui seront le bienvenu chez nous.
Pour commencer, qu'est-ce que vous voulez? Vous voulez commencer par la colonoscopie? Vous voulez commencer par cholangio? Vous voulez commencer
Nous voulons commencer par CRP, CPR, et puis écho-endoscopie, puisque là, on a besoin d'écho-endoscopie. Et ça, puisque je suis en même temps quelqu'un qui gère la RCP pour oncodigestif. Nous avons beaucoup de patients qui ont besoin d'avoir des transferts Mais l'urgence peut être placer de prothèses biliaires, faire des biopsies qui posent problème. Donc, on a besoin d'un centre comme ça de formation.
Okay, this is, so I will conclude for Congo. So what is needed there is ERCP and EOS training. They have nothing done before there, so they need simulators and machines to start this. And I can tell you now, this could be done in the first 6 months of next year. So this is, we already... No, but this is, it's our, we will manage this. This is easy. Non, this is, so, c'est à nous, ça, je confirme, on va faire avec Fuji chez vous pendant les 6 mois qui viennent, écho-endoscopie, cours d'écho-endoscopie, écho-angio sur simulateur chez vous. Ça, c'est un truc à moi à gérer. Hein?
Merci.
OK, merci.
Merci de m'avoir accordé la parole. Je suis Dr Kapinga Magloire. Je suis de la République démocratique du Congo. Je travaille dans le service des patho-gastro-entérologie à l'hôpital militaire de la garde républicaine Colonel Tchatch. Comme mon prédécesseur venait de dire, c'est lui qui est mon maître. Du côté endoscopie diagnostic, nous n'avons pas de problème. Beaucoup plus, ce qui pose les problèmes, c'est du côté thérapeutique. Nous aurons besoin de matériel qui nous aidera afin de bien prendre nos patients en charge. Merci.
It's the same issue about training. That's what I...
Okay. Christopher Epunife. I'm a surgeon from Nigeria. We are three specialists from Nigeria here, so I do not expect to speak for everybody, but there is some aspect I want to bring up. For my, Nigeria is a country of more than 200 million, so there are a lot of potentials there which are untapped. I give a personal experience. I started my endoscopy journey because I attended a CTC training about 10 years ago. And from there, we took off. But then we have only been doing, in that section of the country, especially in the eastern part of Nigeria, we are talking about a population, a place where you have a population of 50 million. Now, they have about more than 6 tertiary hospitals. They actually, at one point or the other, they had endoscopy equipment. But at present, only about 2 functional ones only 2 are functional. So what's the problem? The main problem is the fact that after-sales support is not usually there. And the institutions buy endoscopy equipment, but they're not properly maintained. And even when they have a challenge, nobody actually has an idea of where they can be repaired or something like that. But good enough, my institution, after about a lacuna of our 3 years, we were able to get equipment from Fujifilm. So I expect that they will be very aggressive in supporting us to maintain this equipment, and if there is any challenge, to help us to repair it. Another area is training. The fact that I came here to Egypt actually helped me. So I will beg Professor Ibrahim, let's allow more people to come to Cairo for advanced training, for EUS, for ERCP. That may be a stimulus for them to see how they can also start their system. But that's also not enough. If there is a way whereby we have a faculty that can come to our centers or regions to help us train, that will be much better. Because sometimes when we come here, it's difficult to replicate it in our home country. But in Nigeria, it's actually very much different because one center alone cannot even do. You've had a situation where some regions, especially my own region, I can assure you we have the population where we can actually get enough patients for this procedure. But the problem is that we don't have enough faculty who can come, train the local people, and then they can take off from there. That's actually my own plea in this time.
I understand this is a situation like Rwanda. Nigeria, I have a very good effort with Nigeria.
Yes.
But as you said, you should that we make a training in us,
yes.
But some team should come
yes.
there
yes.
with ECOMET, with simulator,
yes.
to stay 1 week every 3 months. This is what will continue our story in Nigeria. Yeah. I know that for Nigeria, for Rwanda, I know that from Ethiopia, for Kenya, I know. So I understand very well. So what you need that, the same thing. Okay, thank you.
Bonjour à tous, c'est Ismaël Hassani du Sénégal. Je remercie les organisateurs, notamment le professeur Ibrahim Mustafa et toute son équipe, et Fujifilm, mention spéciale à Salim. Et au Sénégal, il y a environ 50 gastro-entérologues pour une population d'environ 18 millions d'habitants.
Excuse-moi. Donc, our friend here is from Senegal, and he's very thankful for this opportunity, and thanks, Professor Ibrahim. And you are 50 million population, no, you said, that's it?
18 millions d'habitants
18 million population and 50
et 50
gastroenterologists.
gastro-entérologues. Ouais. Et les besoins, c'est notamment en endoscopie thérapeutique niveau 2, 3. Et avec la chaîne Senendo, la chaîne de l'espoir et Fujifilm, on a quelques missions qui se font en endoscopie interventionnelle. Et il y a 3 gastro-entérologues au Sénégal qui ont été formés pour la CPRE.
So thanks to Senando, we heard all the discussion about this morning. And Fujifilm, 3 of your fellows, or 3 of your colleagues have been trained for ERCP as far as today.
Mais le besoin est toujours là, en formation des gastro-entérologues, mais aussi des infirmières et d'endoscopistes.
So the main need is training for endoscopists in interventional endoscopy in general and for nurses also. So it's
L'autre souci qu'on a, c'est le matériel. Matériel et bien sûr les consommables qui vont avec.
So the accessories seems to be a problem that is recurrent, and also the technical support from Fujifilm locally. Okay.
This is very important for anyone from Fuji here. And I made that with all the company for endoscopy. I like to mention what the country, but I went to many African countries. I find inside their rooms, 6 from one company, 6 from one company, 6 from another company. Ask what can he said that when the endoscope is broken, we go to another company to go to another endoscopes. The problem was maintenance, and maintenance is very easy. I discussed with many companies, if Fuji create in 2 or 3 centers in Africa for maintenance, this will create a huge problem. Many people have many endoscope of Fuji, very new one, but it's by needle, it is puncture the channel. You stop. So, my opinion, a good center for repairing, it is one of the important things for that. This is for all the company, but now if you are like to stay, you should have a center for that. So this is very important. I asked in the beginning accessory, now it appears like Fusion a good accessory. I asked about sonography. We found the man of sonography was us. So now the big bosses in Fuji, we need one in Cairo. Cairo, they're in one, so we'll create one in Nigeria, one in Rwanda, so it's easy to make repair endoscopy. Okay, next one, please.
Bonsoir à tout le monde. Moi, mon nom c'est Damien Ouattara. Je viens du Burkina Faso. C'est un pays francophone d'environ 20 millions d'habitants pour une cinquantaine de gastro-entérologues.
So our friend is from Burkina Faso, and in Burkina Faso there is 20 million population and only 50 gastroenterologists.
Alors, pour synthétiser les besoins de mon pays, ce sont les mêmes besoins que les autres pays, c'est-à-dire besoins en formation et besoins en équipement. Alors, pour les besoins en formation, juste pour dire que nous avons une école de formation qui formait jusqu'à présent à peu près 5 à 10 gastroentérologues par jour. Et cette année, notre pays a basculé dans un autre système de formation qui nous donne une quarantaine de gastro-entérologues à former à partir de cette année.
The issue is the number of trainees. So you moved from 10 trainees, 6 to 10 trainees per year, to 40 trainees per year. So probably the ability to train 40 is going to be challenging for you.
Et quel domaine de formation en particulier? Eh bien, la formation de base, la gestion des hémorragies digestives, la gestion de la résection des polypes. Parce que oui, la CPRE et l'échoendoscopie sont aussi nécessaires, mais déjà, comment gérer, on va dire, les premiers besoins de base. Donc, gestion des hémorragies et la gestion des polypectomie.
So training needs are mainly for fellows and young trainees, especially for basic endoscopy and especially bleeding and all emergency settings.
Très bien. Le deuxième niveau de besoin, c'est l'équipement, pas seulement pour les appareils. Du reste, nous sommes bien partis, notre collaboration est bien partie avec Fuji, parce que cette année, ils ont déjà installé 4 appareils dans mon pays. Et moi qui vous parle, je suis bénéficiaire d'un appareil flambant neuf. Quand je dis équipement, ce n'est pas seulement les gros appareils, mais c'est par exemple tous les accessoires. Aujourd'hui, celui qui veut se procurer un accessoire n'a pas de circuit dans mon pays, même s'il a les moyens de s'en procurer.
The problem is not the equipment because they have a good collaboration with Fuji and the equipment is coming, but the accessories again are shortage and there is no representation of companies and industries of accessories.
Ça fait que le besoin que je pense qu'il est important d'établir, c'est comment faire en sorte que ces accessoires puissent être accessibles aussi bien pour le système public, en ce sens qu'il faut des passerelles pour ça, et aussi pour tout ce qui sont en privé. Nous sommes nombreux à devoir nous approvisionner lors de nos déplacements à l'étranger, et il serait bien que localement, on puisse avoir un circuit pour s'approvisionner, même pour des choses basiques comme les pinces à biopsie.
So availability of accessories is an issue, public and private sector, and it is as basic as biopsy for steps that are not available.
Merci beaucoup.
Good afternoon, everyone. My name is Arinze Chukwumosai. I'm a general surgeon with a special bias for upper GI surgery. I would like to thank and join the voices of everyone here to appreciate Fujifilm, Professor Ibrahim and Professor Mustafa for the opportunity to be here. I trained under surgeons who had their basic and advanced endoscopic training in CTC here in Cairo. So I followed the footsteps of great surgeons who had come from Nigeria to train here. I would not want to repeat what some of my colleagues have mentioned, and it's key for everyone to understand that there seems to be a recurring issue with support, with availability of trainers, and with availability of materials. I work in the private sector in Lagos, Nigeria. Lagos is arguably the largest city in Nigeria. The population is there. Unfortunately, the public hospitals can't take most of these advanced diagnostic and therapeutic endoscopic services. So you tend to see them more in private practice, of which I participate in. We recently switched service provider from one of the major competitors to Fujifilm, and I think that's on that capacity, that's why I'm here today. I want to plead with Fujifilm that it's important that we do not have the same experiences we had with the previous endoscopic providers with Fujifilm, and I have colleagues who use Fujifilm services and they've been doing very great, and the support has been wonderful on their own part. I'm very much interested in EUS and ERCP. Currently, there are less than 5 physicians, both surgeons and gastroenterologists, that are proficient in EUS and ERCP in Nigeria. For a population of 220 people, that's grossly inadequate. So I think that the direction now is to probably make Nigeria a regional hub for West Africa in terms of the population and bring faculty home. There are a lot of doctors and a lot of centers that have the capacity to do ERCP. What is lacking is the physicians to do so. And I think if the faculty can come to Nigeria, they will have enough people to be trained. I also wish that there will be continuous mentorship. Like one of the speakers said, having this once may not be enough, but if it's neuro where there are refresher courses and having other younger or even physicians in training to have the opportunity to come for such programs like this, I think that will also increase the capacity of the local faculty back in Nigeria to train more physicians that are proficient in advanced endoscopic services. Thank you very much.
So as a standard that you are from the category of that, as I know that Nigeria, we train with us since 20 years, You need somebody to come to Nigeria to continue the journey of ERCP. So like Rwanda, like Uganda. So I understand that very well. This is I discussed with Mustafa about that. There is many jobs for that. Some to come here, some to be trained in their places. So it's very good, very good.
Thank you very much. Permit me to stand on existing protocol and just share with you. My name is Kenneth Tachi from the Kolebu Teaching Hospital in Accra, Ghana. In Ghana, we share many of the challenges that have been enumerated already.
You are from where? From where?
Ghana, Accra, Ghana.
Ghana.
So diagnostic upper and lower endoscopies are routinely available. Therapeutic endoscopy is available in both private and public hospitals to some extent, but not like the diagnostic procedures. We also have capsule endoscopy on intermittent basis. What has been lacking is advanced therapeutic endoscopy, including ERCP and EUS. What we have done over the past 2 years, as a colleague, myself and a colleague have had opportunity to have some training in Japan, and this was with the support of gastroenterologists, Ghanaian gastroenterologists in America. Since we've been back, we've had equipment challenges. They've supported us to try and set up in a private facility, which is, they call the Center of Excellence for Digestive and Liver Health. With support from Fuji, we attempted some procedures in May, and they went well. But there were limitations in terms of some of the facilities and equipment. So we halted, and hopefully, we hope to start in January. What we have done is we have a whole schedule for the procedures, and during each month, we would have faculty from the US overseeing our work so that we build more experience, and then that would go until around November, and then we would get equipment for EUS as well. Because of the interest shown by these people, the public hospital that we work in is also trying to procure ERC equipment to begin with. Fuji has never been, not been visibly present in Ghana, but I think in August, about this year, there was a big launch of Fuji in Ghana. And so what I take away from this meeting and the excitement is that I know they have a center in Côte d'Ivoire for services, and that will be great. So hopefully with their presence in Ghana and the service nearby, we should be able to make more progress with Fuji. Thank you very much.
Now, as you know, that the dream of our dreams in Africa are increasing, that they put many things on the shoulder of Fuji. So we will look for the next 5 years what Fuji will do, because this is a very good idea that you gather Mustafa, all of these people in one place. But again, it's a very big challenge for Fuji to cover all these points. We hope, we look for you. We look and we see what happens in next 2 years, what you will do. Okay, this is a promise. Everything is recorded, huh? Take care, huh? Okay.
Thank you very much. I'm Dr. Okello Okumu. I'm from Eswatini. This is my first visit to Cairo. This is my first visit to this meeting. And in these short few days, I've learned many things. For example, I've learned the many things that Professor Mustafa has done. I would like to inform you that on that big map that you had of the continent of Africa, there is a small country in the southern part of Africa called Eswatini. Please add it to that map, because I'm here now.
I have this problem because I don't add before Togo, Benin, because there are 10 millions. I take care for the country with 100 millions or more. But now it's a bad mistake because I work with these people since 20 years. But I feel that I have a big things, because if I found Togo last year, one of them come, we have no polypectomy. So I did that, did my job very well, because I take care from the big country, but any country is very important. So you are absolutely right, that before I don't put Togo and Benin in my lab. I don't know them. So you are absolutely right. There are men coming from Comoros, and we don't know about Comoros before. But when he come, so you are absolutely right. I am sorry, but I will put your names.
It's not a problem. Many times, South Africa overshadows most of Southern African issues. For example, my colleague, my very good friend, was speaking about South Africa, and he seemed to be speaking for the whole of Southern Africa. It's not his fault, but that's what it seems like. We can do better than that. It's a small country bordered by South Africa and Mozambique, and the population is about 1.2 million. And at the moment, there are 4 places with endoscopy equipment. I started doing advanced endoscopy about 10 years ago there. And initially, I used equipment from a competitor, but for the last 5 years, I've been using Fuji. And High-Tech Medical is excellent at sending me the supplies whenever I ask for them, but they don't follow their equipment. So I really don't know a lot of the people there, and I think that is why I haven't been aware of such meetings, and my colleagues are not aware of such meetings, and I'm hoping this is the beginning of many interactions to come. Because it is in such meetings, the last 2 days I've seen new equipment, I've learned about what he's doing with the ultrasound, I've learned about Mikoto and so many other things from these meetings that we get to learn about these things. The health needs of Africa are many. They exist. But we don't know about them because we haven't written about them, but also because we don't reach the local populations. There is a big gap between the needs of the people there and us in practicing medicine and the industry, and that gap is filled by costs. So it is important to train the doctors, to keep the doctors informed about what's going on. And African countries are now opening many more medical universities. So the numbers we've been seeing of doctor-patient ratio is the number of doctors in gainful employment. But a lot of African people are training in China, in Taiwan, in Eastern Europe, and there are many doctors. If we train them, we can bridge that gap. But the other big gap is because of the cost of the equipment. Where I work, I'm part in private and our foot is in the public sector. And my facility is lucky because we've got a working arrangement, a public-private partnership through which people from the public service can access the services that I offer in the private facility. Last year, we purchased a duodenoscope from Fuji. This year, I've started offering ERCP. If somebody is to pay for it off pocket, the cost is almost unaffordable. But through this public-private partnership, we're able to extend it to the people. So us as health workers and you as industry need to think about, on a continuous basis, how we can bridge this gap so that we map out what the health problems are, what the needs are, and we can meet the people at their area of need. That's what I need to say for now.
Yes, thank you. I'm sorry that I will put your name next time. The name of the country.
Good afternoon, everybody. Thank you very much, Prof. Ibrahim and Prof. Mustafa and all the participants of this great opportunity Congress. I'm Dr. Youssef Saad, originally Egyptian, proudly Egyptian up till now, but I'm based in Namibia, bordering country to South Africa for the last 20 plus years. I'm working in private practice and I'm working in academia in the School of Medicine there, which is a baby school of medicine, only 15 years old. And I want to echo what my colleagues and friends are saying about the Southern African area, because it's a very known area where there is a very big paradox. So you find some very big world-class universities, Stellenbosch and UCT and so on, which is overshadowing the whole picture. The state system is not very strong because of finance and because of not very good management, while the university systems and the private sectors are, first-class world practices and so on. Namibia is a big country space-wise. It's almost the same size of Egypt, but with a population of 3 million.